faces in the crowd there. And I've been there for 10 years, but I've been a physio for 16 in June. So I've been long interested in how people with low back pain tick. All of you will know that sometimes it follows that nice pattern that we all like to see. They come in, we do our therapeutic intervention, we give them exercises, they comply, and they get better. Another time it doesn't follow that straightforward path. That has been my bee in my bonnet for my whole career. So it was a blessing to be able to do this master's this year and have a real good look at the military population from a longitudinal perspective to see what works and what not. So that's what I did my thesis on. Oh, just to go back to that, just to show you who were on my committee, a lot of you will know Dr. Catherine Harmon from Dow. You will have been taught by her, or she would have been a member of the faculty when you were there. And another person of interest there was Dr. Jill Hayden. So Jill does a lot of work. She's in the epidemiology department, does a lot of work on prognostic factors of low back pain. So it was amazing to have her as my supervisor. It really helped with the quality of the study. So just what I'm going to go through today, give the rationale why I chose to do the study, some objectives for doing my master's, go through my methodology and results. I can go through in as little or as much detail of this part as you guys want. The clinical implications, and just overall the conclusions that we found.
You skipped one.
I skipped one.
Went fast.
I skipped two. You can see that I'm really good with low back pain, as we all know, is the most prevalent form of musculoskeletal pain and one of the most costly conditions to manage in occupational health. It's gaining a lot more attention now in the world because as of 2010, the Global Burden of Disease Study has ranked it now as the leading cause of musculoskeletal condition disability internationally. So we all know that. But in light of all this, there's never been as much research done on low back pain, and there's never been as many interventions available for low back pain and imaging studies and all these different ways to treat low back pain. But the ironic thing is that the last international convention on low back pain is, are we even getting any better at this? Because the outcomes for it and the disability and the prevalence of it is worse now than it was 30 years ago. Very ironic. In our population, it's definitely the most commonly reported condition that we see that's significant enough to impact their ability to do their job. So their ability to deploy, maintain operational status, perform their daily activities, and ultimately remain in the military. So $60 million in the military goes towards musculoskeletal pensions. Yeah, and low back pain makes up a large proportion of those. So all of you will be interested in outcomes for low back pain. It's very important that we measure our outcomes. And the most common ones that you will see in clinics and in research is pain and level of function, and other ones that are associated with return to work or number of sick days or things like that. And these are really, really important to us as clinicians. They're also important in research to make sure that our practice is effective. And it's also important to the patient because they want to feel better and they want to be able to do more things. But my interest, outcome of interest was healthcare seeking, which may sound funny to you. I'm sure most of you are all in private practice. Some of you guys work in the hospital. Majority are private practice. Because you love to see them all coming in the clinic. But at the military, we have a lot of people coming for a very limited amount of resources, and I'm sure a lot of your clinics get the outflow from the military, and we're like, what is making all these people come back again and again and again? So just to go through, Anderson has done a lot of work since the 1960s. He's revamped it in the 1990s, and now there's other researchers picking it up in the 2000s on what makes people seek care for a health condition. And what makes it interesting for the military as opposed to the general population is the healthcare system that we provide and the resources that they have access to. So it's very contrast to the general population where you have your health plan and you get so much for that health plan, or your WCB claims where you have so much money to access physiotherapy or any other intervention. But we really do have an unlimited access to care. If you're sore, you go to the doctor. During work time, you get your same pay. You can take as much time off during the day to attend your appointments. So it's a really interesting scenario. And we're measuring their perceived healthcare status. Also, our objective outcomes. But what I was interested in is, what are these characteristics that are making the people come back to see us again and again and again? And why this was a gift this year is because I really got to look at low back pain, not as a physiotherapist, which I've done for a long time, but as a epidemiologist, to take a step back and look at it from that overall picture, from the population health picture. So we're used to looking at it as acute, chronic, okay, that's subacute, somewhere in between. And most people with non-specific low back pain in particular have a really good outcome at a discrete point in time. So typically when a person presents to us, we manage them however way with all our tools, and a lot of people do well with the outcomes of pain and function, we hope, right? Particularly when those acute patients. Then we have this chronic that we all just want to put under the rug and not want to deal with. But the epidemiological view of low back pain is more of this trajectory. What is happening over the course of the person's life? And these acute and chronic get blurred with this recurrent status. So instead of people coming in and us pigeonholing them, it is looking at them more along how long they've had this problem. With the outcomes that we usually look at, pain and function, if we're only looking at those over a long time, there's been many epidemiological studies now done, and for those that seek health care for their low back pain, after 1 year, between 41 and 66% of people have not recovered their full function, despite what we do. Okay? And 73 to 80% still have pain. So, is that a bad thing? Is that a good thing? How much pain? How much is their function limited? But the overall thing is that it doesn't go away. It doesn't go away as easy as we would like to believe low back pain goes away. So Katie Dunn and her colleagues have done a really groundbreaking study on the trajectories of low back pain. They followed patients for 1 year and then followed them up again at a 7-year point. And they came up with 4 trajectories that people fall into 4 distinct classifications. So there's the persistent mild. They are people that have daily back pain, they've had it for years, but it doesn't really limit their function a lot. They can do most things, and they're not usually the ones that seek care. And if they do, they're pretty easy to manage. Then we have those that fall into the recovery trajectory cluster. So they are those that come in, we like these people. They come in and they're in the world of hurt. And we work our magic, and they get better, and they really like us. And then they go away, and they may come back again a year or 2 later. In a world of hurt, we settle them, and they go through that cycle. We have the severe chronic. People that, no matter what you do, don't seem to get better. And they're in a world of hurt, and you really wish that we could help them a bit more. And then we have the 4th cluster, which is fluctuating. So there are people that may have this mild, low-grade chronic pain that flares up from time to time into these chronic conditions. So the interesting thing about Dunn's work is that 7 years later, people in this category remain in this category. People in recovery still follow that same pattern 7 years later. Severely chronic, no matter what intervention they were having, we're still dealing with their chronic pain. But this fluctuating one, those people that were living with a low, consistent level of pain that had these bad flare-ups, either we're seen to go here, a better prognosis, or here, right? And although that's a small group, a quarter of the sample that they looked at, that's a very interesting one to us because we get a lot of that. A lot of people that have been dealing with pain for a long time and are having these flare-ups that are getting closer and closer together and more difficult and difficult to manage. And what makes them go that way and what makes them go that way. So over the past 5 years, there's been an increase in healthcare seeking for musculoskeletal care in the military, whereas other access to other health services such as doctors' appointments, nursing services remain stable. So that's a big thing for the people that are trying to manage our resources. Good for some of the clinics that we outsource to. Healthcare access is freely and easily accessible. They don't have to pay to come to see us. There's a limit on their services when they go to see you, but really, as long as they're recovering with us, they don't have a limit to their access. And there, up to this date, there hadn't been, or we're not aware of, I could not find any other work of a longitudinal study of the impact of low back pain on the Canadian forces from a healthcare seeking perspective. So the objectives of my study was to explore the relationship between prognostic factors of low back pain that are seen in the general population and the outcome of healthcare seeking in the military population. But also it was to examine the specific factor of pain-related fear and see how that was associated with healthcare seeking in our population. Is there anyone out here that commonly measures pain-related fear avoidance behavior in their clinics? No?
With her D&D class.
Yeah.
Right, at the
With some
when a D&D patient comes in, we do.
Thank you.
That's a great answer. Sarah, Captain Godfrey's sitting right there. So when Jill and I were talking, my supervisor, not Jill, Jill Hayden, I was talking about how I wanted to contrast the biopsychosocial model and the biomedical model. And her reply to me was, why would you talk about the biomedical model? No one talks about just the biomedical model anymore. I'm like, yeah, we do. Yeah, there's a lot of people that just talk about the biomedical model. She's like, how can that be? She could not get her head around it. So in research, the perception is that we're all working from a biopsychosocial perspective because it's been around for 25 years. It's been the dominant model for care for lots of different conditions for 25 years. And a lot of research has been done on this. So Engel, way back when, a psychiatrist, was the first guy to come up that medical condition is not just based on the physiological disease process that they present, but it's more of an aspect of their behaviors and their cognitions around their condition, and also the context of which they exist, so their environment and all of the things that might influence that. And it was Waddell in the 80s who came up with the biopsychosocial model for back pain. So we have pain, we have their nociception of how they, the stimulus that they have, but also, so that's our bio component, but also we then have the psychological component. So that's their attitudes and beliefs towards their low back pain, the psychological distress that they may be dealing with at the same time, so depression, anxiety disorders, and the behavior that they exist because of their low back pain. And then the social environment is the socio part of the model, and that can be things like their culture, their work environment, their compensation. All of these things play a big role. So when we look at this, the relevance to the military, you know, people get injured a lot in the military. They have highly active jobs. They have to maintain a certain level of physical status, and they are deployed in some pretty repetitive, grueling conditions. And, you know, there's lots of, we image a lot of our patients, and there's lots of things showing up in these images, and the clinical presentation of these patients show a lot of things, as you will know if you treat our thing. There's a lot of post-traumatic stress disorder in our military, a lot of depression, comorbid. I'm interested in the pain-related fear, their beliefs and attitudes towards it, because they don't have a lot of autonomy to refuse a task if they're in pain. So if they have a sore back and they have to lift the box, they've got to lift that box. So you can see why they're afraid to injure themselves again. They have a very well-established Veterans Affairs compensation system in our military, so you can be compensated for your condition and still work. So there's a real incentive there, or a disincentive, however you look at it, to have this condition acknowledged if it's work-related. And the whole social stresses that they have. They're deployed for many, many months, away from their families, high divorce rate, lots of financial stressors. I'm sure they tell you when they come in the clinic. I'm sure you hear all the stories. They're selling their house and they're splitting up with their wives. I mean, but I must say that the predominant model still in our military is the biomedical model. They really want to say that we have a very active population, and if we manage them biomedically and we do the right things, they're going to get better. And they've tried to fit these round pegs into square holes for a long time, and it's frustrating with the crew that aren't following that. Now, a lot of you will get some of the guys that are, and gals that follow this model, and it's a pleasure to treat them. They're very motivated people, and they do really, really well. But there's a section of them that struggle. So Jill Hayden, my supervisor, she has done a lot of work on prognostic factors in the general population. And she has done a systematic review of studies and systematic reviews. So a very well conducted overview of all the well-conducted studies and reviews of studies on what are the general prognostic factors for poor outcome and barriers to recovery. So if someone is following a nice pathway, yeah, some of these biomedical things that we're finding on our assessment are very, very important. But these people that don't have that straightforward outcome, the things that will be associated with fall into the biopsychosocial domain. So you have your low back pain episode characteristics. They're high are Roland-Morris and Oswestry scores. Presence of leg pain. Older age, poor general health. The psychological characteristics such as their increased psychological or psychosocial distress. Depression is a big one. The negative cognitive characteristics such as fear avoidance behavior. Their work environment, so poor job satisfaction, heavy workload, poor relationships with the colleagues. And yeah, so, and they come up, they're the ones that came up consistently. She looked at 221 different factors, and those ones were the ones that came up most consistently. So as I said, my interest is definitely the pain-related fear, because we don't traditionally screen for that. We're screening for it in our back rehabilitation class, and there's a high level of people that are coming into that class with a high level of pain-related fear. A lot of you familiar with the fear avoidance model? Do they talk about that in school anymore and things? Yeah. So the Blaine and Linton, many of you will definitely have heard of them in the past, came up with this fear avoidance model where they say that the way that someone interprets their low back pain experience has an effect on their road to recovery. So if someone interprets their pain experiences as non-threatening, that it's a part of a condition, a long-standing condition, a relapsing and recommitting condition, and they're encouraged to work through that pain and remain active despite the pain, they should, as they confront their systems and work through that, have a good road to recovery. However, those who maladaptively interpret their pain may have an association of fear of movement re-injury, have subsequent